Welcome to the last video in this pre-matriculation series. In this video, we're going to talk a little bit about the action of inotropic drugs and how we can apply what we've learned about the way that the heart works to the way that drugs work in general. And then we're going to summarize a little bit some general things that I expect you to take away from this and apply elsewhere. So first of all, at the very beginning of this lesson, I went through a series of of cardiac drugs. And among those, I mentioned the sympathomimetics. Now, all these drugs that increase the force of contraction of cardiac muscle are called positive inotropic drugs because they increase that force of contraction. Okay? Typical examples in this class: dopamine, dobutamine, isoproterenol. Okay? So the way that these drugs and most of the other drugs that act like them work is they increase calcium in the cytosol during contraction, and therefore they increase the force of contraction. The sympathomimetics do that by mimicking the action of norepinephrine on the heart. So if instead of norepinephrine here, I'm using something like dobutamine, then what will happen is isoproterenol, probably a great example. What will happen is the isoproterenol will come in and it'll bind this beta receptor instead of norepinephrine. But the difference being, this is endogenous, the body releases it when it wants. Isoproterenol you give to the patient and you make the heart do what you want. You leverage the physiology of the cell in order to make the heart do what you want it to do. In this case, the isoproterenol binds the beta-adrenergic receptor, that activates GS, that stimulates adenyl cyclase, that increases the conversion of ATP to cyclic AMP. Cyclic AMP goes up in the cell, and it binds to protein kinase A and activates it. Protein kinase A has its targets in the cell. It the system acts upon the pacemaker channel to increase its activity. It increases the activity of the L-type calcium channel. That increases the heart rate by increasing the activity of these channels in the SA node and causing that potential, that in between action potentials, to rise and hit thresholds sooner, and you'll get more action potentials per minute. You get an increase in heart rate. You also get more calcium influx through the L-type calcium channel in the ventricle. Calcium accumulates in the cytosol. You get more force of contraction because you've got a higher calcium. Okay. You also have an increase in the SR calcium pump rate. That increases the calcium accumulated in the sarcoplasmic reticulum. That increases the amount of calcium released by calcium-induced calcium release. That increases the calcium in the cytosol. That increases the force of contraction of your cardiac muscle cells. Okay? And we get all this right up to the cellular level by using this isoproterenol and leveraging the effect of the sympathetic nervous system upon the cell. Okay? But the difference is we're making it do what we want by giving it something that looks like norepinephrine that binds this beta receptor. Okay? So, we increase the force of contraction by increasing the myoplasmic calcium level during the action potential, and that increased force of contraction leads to an increase in the stroke volume. So as cardiac muscle contracts, the chambers of your heart get smaller, and the more the force of contraction, the more blood you eject from those chambers out into the system. So I increase the stroke volume. Cardiac output, heart rate times stroke volume. Increased force of contraction of cardiac muscle, increased stroke volume, increased cardiac output. My tissues are perfused better, and I increase my blood pressure. Okay? Note that your heart rate also increases. Cardiac output, heart rate times stroke volume. Heart rate goes up, cardiac output goes up. Cardiac output goes up, blood pressure goes up. Blood pressure goes up, you perfuse your tissues better because that tissue perfusion is dependent upon the blood pressure. Blood flows from high pressure to low pressure. You want to increase tissue perfusion, you generate more pressure in the arteries, and that will perfuse your tissues with more blood, okay? All right, so this is the way that this works. We started on the microscopic level. We had isoproterenol on the last slide. We go through the cells, and we increase the force of contraction. That has an effect on the organ. We increase the stroke volume. We increase the stroke volume. We increase the cardiac output. We increase the cardiac output. We increase arterial pressure. We increase arterial pressure. We get better tissue perfusion. Our patient gets better, okay? So you start on the submicroscopic level, and you work your way up into something that you can actually see in a patient. Increased heart rate, increased cardiac output, increased blood pressure, increased tissue perfusion. If you can do that throughout the 2 years that we are giving you to study, through the diseases and the systems that we give you, then you're going to be in good shape, and you're going to be able to extend that into whatever area you want and whatever disease you want. You'll have a very general understanding of how things work. So let's talk about some of the general physiological things that we've learned here. First, substances flow from high pressure to low pressure, fluids and gases. This is something that comes out of what we call Ohm's law. Most of you guys know Ohm's law as V equals IR. Well, voltage in an electrical system is equivalent to pressure in a fluid system or in an air system. So delta V provides the potential for electrons to flow. Delta P, the difference in pressure, provides the energy that allows fluids and gases to flow, or at least it provides the force that allows them to flow. Okay, so fluids and gases flow from high pressure to low pressure. Ohm's law we'll talk about a lot more very quickly. Tissues are compliant. That is, some stretch easily, some don't, and this affects their physiology and their pathophysiology. In the case of the lungs, you decrease the compliance, you make the lungs heavier, it's harder to expand the lungs, it's harder to increase their volume, we get a restrictive lung disease, okay? Substances diffuse from high concentration to low concentration, down concentration gradients. And those gradients are established by ATP-driven transport, either directly or indirectly. If it's secondary active transport, like the sodium-calcium exchanger, it's an indirect. It uses the sodium gradient, which is generated by the sodium-potassium pump. If it's the sarcoplasmic reticulum calcium pump, then it's using ATP directly. That's primary active transport. And calcium gradients are maintained through active transport through the use of ATP. Diffusion across membrane can be controlled by the opening and closing of channels. So if I open a calcium channel, calcium will go from high concentration on the outside of the cell to low concentration on the inside of the cell and accumulate inside the cell. If I close that channel, then that stops. And calcium stops diffusing across the membrane through the channel, okay? Diffusion is efficient over short distances, and your body goes to great lengths to minimize the distance of diffusion. Once again, remember pneumonia, where water accumulates and the tissues become edematous and thickened, and you increase the distance of diffusion, and that can limit how much oxygen can get into your bloodstream. Much of the control of the organ systems of your body is through the autonomic nervous system. Remember, we use the heart as a prototypical example where you increase and decrease your heart rate and increase and decrease your cardiac output by altering the two branches of the autonomic nervous system, the sympathetic and parasympathetic branches. The autonomic nervous system has tone. That means that the branches of this system don't work like light switches, they work like volume controls. And there's always some volume there, and it's a question of whether you're turning the volume up or down. But there is always tone, and there's always some activity of both branches of the system, okay? You're not just flipping it on and off. And in order to truly understand how medicine works, you have to understand how changes take place on the subcellular level and how that can be translated to what you see on the level of a whole patient. In other words, you should be able to look at a patient and look at the signs and look at the symptoms that are being exhibited, look at the changes of whole organ systems, and be able to make a guess as to what is happening on the submicroscopic level, down from the organ to the cells to the subcellular to the proteins, and on and on and on. And on the other hand, you should be able to take changes on the subcellular level, which you can initiate, let's say by giving someone a drug like a sympathomimetic, and you should be able to work from the subcellular level up through, the receptors, the membranes, the cells, the organ, and finally into the effect that you can see in a patient, so that you can translate subcellular effects to macroscopic effects that can be seen in people like you and me just by looking at you and me. Okay? This is what medicine, true application of medicine is all about. And although what you're going to find is that you can't always learn how things go up and down that scale, we're going to expect you to be able to do it as much as possible in sample systems so that you can take that and translate it into your clinical years, and you can apply it to become someone who isn't just memorizing what happens, someone who can actually translate changes up and down the ladder and apply apply medicine the way it's supposed to be applied, and to learn in medical school the way that you're supposed to learn. Okay, so having said that, that's my brief introduction to the physiology of the system. Thank you for your attention, and I'll see you guys when you arrive on campus.